Okay, good evening, everyone, and welcome to this edition of the Clinix webinars that are meant to give clinicians, doctors, and other health professionals an opportunity to refresh our minds in the form of continuing medical education. Clinix has been running these now, sponsoring them since 2020, and I'm glad that they are continuing. And I think these webinars are sponsored by Clinix free of charge to all those who wish to register for the webinars. And all you have to do is just to take 1 minute of your time to register your name. And don't forget your email address so that we can get subsequent invitations from the team, but also your registration number with the regulator that you are registered with, whether it's South African Medical, South African Nursing Association or Nursing Council, not Association, Nursing Council, whether it's a Health Professionals Council or any other council that you are registered with, including Pharmacy Council and so on. They are free to register to enter our webinars. So free of charge, you don't have to pay anything. The webinars are registered with the HPCSA for CPD points. And I think most practitioners would have received letters in recent weeks advising them that from 2024 April onwards, 2025 April onwards, CPD points will be considered when practitioners have to register or to pay their subscriptions for the year. So I think in a way, I think you also gain price, not only in knowledge, but also in CPD points, both clinical points, general clinical points, but also points in ethics, CPD points. They call them CEUs in continuing education units. So that helps a lot. The Clinix has been sending out certificates in the past for those who have attended in full. But and on top of that, HPCSA also sends you on your email address that you've given to us a confirmation of your CPD points and how many points you managed to receive by registering for these webinars. But maybe I should share with attendees that from now on, you will just get confirmation by email. And if you don't, please let us know. It usually happens in the week following the webinar, next week, Tuesday, Wednesday, Thursday or so, that your CPD points have been automatically registered against your name with the HPCSA. So you'll only get it, you won't be getting the certificate anymore from Clinix itself, because it was like we're doing double notification. We were sending out certificates, but also you were receiving the notification from confirmation of your CPD points from HPCSA. So the confirmation will continue, but you will get notification to that in that form only, not by certificate. Today, I think the person from marketing who is assisting us in the background is Aviwe, but our speaker, I am Dr. Ernest Kenoshi, by the way, for those who are doing the webinar for the first time. I have hosted before to assist both Dr. Bila in the past, who's been our webinar master for many years until recently, but since about 3 months ago, our webinar master is Dr. Morwesi Mahlangu, who is the Chief Medical Officer for Clinix Health Group. She's unfortunately not available tonight, this evening, but I am here to assist and stand in for her. Our speaker today is Dr. Zweli Zondo. Dr. Zondo is a qualified orthopedic surgeon, qualified at VERTS, MBSHP, but also he is med with VERTS. Of course, he's also done his college fellowship with the College of Medicine of South Africa. I must let you know that he's also got an additional special qualification as a fellowship in spine orthopedic surgery as well. So he specializes in the spine. He works at one of our hospitals, September Hospital in Roodepoort. But he also has got interest in trauma, in hand surgery, and as well. So, yeah, but it's mainly on spine as well. Maybe let him talk for himself. He will do the presentation for about 45 to 50 minutes, and then we'll have a question and answer session. And thereafter, at that time, I think everywhere will open the mics. During question and time, people can post questions even before he finishes on the chat group, on the chat facility. But when we come to Q&A period time, you can also raise your electronic hand, and then we will recognize your hand and attend to you if it's a comment, or whether it's a comment or a question. I think that's all clear, Doc. Over to you, Dr. Zondo.
Good evening, colleagues. So the topic I decided to talk on today is back pain. The reason for this is because it's a very common problem, and we see a lot of patients coming to our rooms for consultations, and sometimes we get a bit confused as to what they're trying to say. So much so that some of our colleagues might not be happy, basically, to see patients with spine problems. So this is not by any means an attempt to try and cover everything in spine. So back pain can be caused by so many other things. And therefore, I'm not trying to cover every single topic here, but I'm going to be touching on conditions that commonly affect the spine, which we need to be comfortable with in terms of how do we get to that diagnosis, and then how do we treat going forward. So just to look at the introduction. So back pain affects 50 to 80% of people in their lifetime. It's a very common problem. It's second to respiratory infections as a cause of doctor's visits. It costs the United States an estimated $100 billion US annually. It's quite costly, and can be caused by many conditions, degenerative disorders like your lumbar spinal stenosis, lumbar disc herniations, muscle strains, spinal instability, and other causes like your trauma, infections, scoliosis, as well as referred pain. I'm mentioning it intentionally because not every patient who comes to your rooms and tells you that they've got back pain actually has got a problem with the back. Sometimes it might just be someone who's got fibroids and it's a referred pain. It could be someone who's got renal problems and they've got referred pain. So you always have to have it in the back of your mind that it could still be referred pain. So you still have to look for other sources of pain that might be originating somewhere else, but presenting as back pain. And sport injuries, we can't leave that one out as well. Some of the risk factors for having back pain: obesity is a big risk factor. Smoking is a big risk factor, and the gender, both in terms of gender. So both men and women have back pain sort of similarly in terms of numbers. It's just the cause of back pain tends to be different. For men, we tend to get a lot of back pain as a result of a risky lifestyle that we sometimes engage in. And nowadays, one cannot ignore the effect of back pain that one can get just from prolonged hours of sitting. One of the other causes would be lifting heavy things. Especially for men, we like lifting heavy things because sometimes somehow it makes us feel good about ourselves, that we are strong. But ladies also do lift heavy things, especially during the times of moving house. And then when it comes to history, it is important to ask open-ended questions. What has brought you here today? Let the patient explain themselves. Then they can tell you, when they explain themselves, they'll give you like an overview of what it is that they are there for. And then also, if you ask a patient an open-ended question, it makes them feel like you are willing to listen, as opposed to when the questions are just directed and they're just answering your questions. It ends up feeling like it's you who's in charge. When a patient comes to see you, let them talk and let them explain themselves why they are there. And then after they've given their version of what is the problem, then you can ask more questions which will now direct you to what might be the problem. So it's important to ask, what work do you do? Because this can also be part of the reason why they have pain. So this will give you guidance in terms of, could this back pain be related to work? Or is it something at work that can be adjusted, that can then help with this patient in terms of the back pain? It's important to know, when did the pain start? Because you wanna know, is it an acute onset of pain, or is it a chronic onset of pain? And if it's an acute, you want to know, why has it started now? If it's a chronic problem, you also want to know what happened then at that point in time that may have started the pain. They may have been involved in a car accident. They went to the hospital. They were told nothing was broken. And then they go home. And then 2-3 years later, they're complaining of back pain. And that incident might be the reason why they're now having this problem now. So it's important to get a thorough history so that you understand what is happening and what might be causing this pain. What makes your pain worse and what makes it better? Patients will tell you that their pain is worse when they are standing up straight and walking, compared to when they are leaning forward. And if they are leaning forward, the pain is a bit better. A patient who tells you that information most likely has got what we call spinal stenosis. A pain, so how you know if someone has got spinal stenosis, just sort of on history. When they standing up straight, they're going to be very uncomfortable. And when they're leaning forward, so some will tell you that they're more comfortable when they push a trolley. And the only way you push a trolley is by leaning forward. Some will tell you that when they're going to gym and exercising, they're happy to sit on a bicycle and cycle. And that's comfortable for them. That's not too difficult for them. When they're leaning forward, it opens up spaces at the back, which gives them some relief. So a patient who tells you that they've got this type of symptom, which improves when they lean forward, you must think that they probably have spinal stenosis. And if that's the symptom that they're giving you, if they've never had an MRI, you probably need to have an MRI done, because you need to diagnose this condition. And then what have you tried to help you with your pain? This helps you in terms of understanding, how bad is this problem? Have they seen someone else? What have they tried in the past to try and help themselves, to help them with the pain? If they've seen a chiropractor, they've seen a physiotherapist, they've tried painkillers, it means the problem is serious, because it bothers them that much that they need to go and see and seek help. So it is important to understand what they've tried, because if they've tried all the other treatments before they come to see you, you can now say, I'm going to refer you to physio if they've already told you that they've tried physio, it failed. So this gives you an understanding of what they've tried and has it worked or has it not. Do you have pins and needles on your arms and legs or areas of numbness? The reason why I put it like this in terms of pins and needles and areas of numbness is because some patients won't tell you that they've got pins and needles or shooting pain or cutting pain or that type of pain when they're describing the radiculopathy on their arms or on their legs. Some will tell you that they just have got areas of numbness. Areas of numbness in the upper limbs or in the lower limbs should alert you that that patient has got radiculopathy symptoms. And in that case, a patient who has these types of symptoms, if they have not been investigated, they need to be investigated. And the most reliable investigation for such a problem would be an MRI. An MRI is indicated in a patient who's got these symptoms. Excuse me. Have you noticed any difficulty with your walking? Do your legs feel tired? The importance of this question is to alert you into spinal stenosis. This is what we call spinal claudication. It's similar to vascular claudication, but this one occurs as a result of compression of the spinal cord. So the flow of information from the brain to the legs, there's a compression point, so it doesn't flow as freely as it's supposed to be. So they then feel like their legs are tired and they feel weak and they need to sit down and rest and in order for them to be able to continue with what they're doing. This is an indication that you have a patient who's got spinal stenosis and you need to investigate this patient. An X-ray alone will not suffice. You would need to do an MRI to find out how bad is this stenosis, because if this stenosis is really bad, you might find that this is a patient who's probably running a risk of getting what we call a coda equina syndrome. And you might, if you pick it up, you might be able to refer this patient in time before they end up with that type of a syndrome. Any difficulty with your fine motor movements of your hands, like opening bottles or feeling like the hands are clumsy, things fall off your hands? This is an indication that there's compression higher up in the spine, most likely the neck. So the difficulty with fine motor movements of the hands, it occurs when patients have got in patients who have got what we call cervical myelopathy. If there is compression in the neck, which is quite significant, it presents as upper motor neuron symptoms, which will then manifest as increased tone and reflexes. And part of that increased tone will manifest in the lower limbs as tightness around the adductors. And when these patients walk, they feel like they're drunk. They feel like they're going to fall over because they feel like they're swaying over. So as a result, they try to keep their feet apart, and their walking is also slower as well when they walk because they're spastic, they're stiff. So this is an indication that you're probably dealing with cervical myelopathy. If your kids tell you that you've quite clumsy, things fall off your hands, you might be having a cervical myelopathy, and the diagnosis there would be based on an MRI to show that there is definitely compression in the cervical spine, and then you have to look for whether there is a cord signal or not. The cord signal being the grayish look around the area of compression, which is a marker that the compression has been significant, and there's an area of ischemia in the spinal cord itself, because that tells you that this patient is most likely not going to do well even after the surgery. But you need to be able to say something like this prior to doing the surgery for that type of a patient. If they already have a cord signal, that's a poor prognostic marker. So preferably, you don't want them to get to that stage before you refer them. If they can be referred earlier, the symptoms might improve if they do get the decompression that they need. Do you have difficulty with your bladder or bowel control and any sexual difficulties? So here, if you think about your spine, if you've got a compression of your spine at the level of your coda equina, so your spine normally is a uniform structure until about L1 for a lot of people, and below L1, the single unit of the spine, then it branches into a bundle of nerves that look like a horse tail. So that's what we call the cauda equina, where it comes from. And then the other thing is so now if you've got compression, so we all have cauda. What is important, I must emphasize, is some people talk about cauda equina as if it's a bad thing to have. No, cauda equina is something that we all have. It's the syndrome that is bad. Cauda equina syndrome is the one that we don't want to have, but the cauda equina is something that we all have. It's normal. So now it's the compression of the cauda equina nerves that becomes a problem, and then that's where the syndrome comes from. And how does this syndrome manifest? Is through difficulty controlling your bladder and bowel, meaning you get incontinence. You get sexual difficulties, be it in a form of erection difficulties, be it in a form of ejaculatory problems for men and women as well. And the other important finding would be if they've got complaints that their legs feel weak and they have difficulties with the walking. The other important thing there is what we call settled anesthesia, which is the numbness around the upper inner thighs. It feels like you've been sitting on a horse for a long time, but you know you haven't, and that should be alerting you that something has gone wrong. So you've got numbness around your genital area, which you cannot explain. Why is it there? You probably have got a compression of the cauda equina nerves, and therefore you're manifesting some of the symptoms of the cauda equina syndrome. Sometimes the numbness around the genital area, perianal area, might be just the one sign that alerts you that this patient has got cauda equina compression. So that type of a patient who gives you those symptoms, get an agent MRI done. You might just make an early diagnosis of this syndrome, which might improve the patient's outcomes, because cauda equina syndrome, once it happens, the outcomes are quite poor. The other thing that's important is exposure to patients that have TB. This is very important because in patients who've got spine, and I know sometimes we forget and ignore that we live in a country that has got a lot of TB. And in private, sometimes we make it look like you're not going to see patients who have TB, but TB is everywhere. And if you're not thinking about it, you're going to miss it. So it's important to ask about TB exposure, and as well as the symptoms related to TB. One of the most accurate symptoms that will tell you that you're probably dealing with weight loss, could be cancer, it could be many other things. If it's unintentional though, it has to worry you, because you have to ask yourself, why is the patient losing weight if it's not planned? But for you if you're thinking along the lines of TB, if they don't have TB contact, but they have drenched night sweats, you might be dealing with TB. Drenched night sweats are very typical of TB. Anyone who's sleeping, they should not have drenched night sweats. If they do have that, they consider that you might be dealing with TB. The thing is, with TB spine, not everyone who comes to you will tell you that they're coughing. Some of the patients who come to you who have TB spine, they actually have no symptoms in the chest, no coughing, no sputum, nothing. So if you don't consider that you might be dealing with TB, you're going to miss it. The other thing is family history of cancers is very important, and finding out about previous cancer diagnosis. So some patients, if you ask if they have family history of cancer, they will tell you no, and they will not openly divulge that they've actually been diagnosed with breast cancer maybe 3-4 years ago, unless you ask, have you been diagnosed with any kind of cancer in the past? They might not tell you that information because it might be a conversation they don't like having, but unfortunately, it is a conversation worth having because it might be a recurrence of the same tumor that is now causing the pain to come back, and they might not even want to go that route in terms of, could this be that cancer that has come back? And it is a possibility that it may have come back and gone and metastasized into the spine. it is important to ask your patients also, if whether it's pain in the neck or pain in the, if it's a neck, ask if they have pain in the neck and they have pain in the arms, let them rate the neck pains as well as the arm pain. A patient who's got more pain as a result of nerve compressions benefits from surgery better than the person who has pain that originates from just the neck. So in other words, what I'm saying there is, if a patient presents with neck pains, but no arm symptoms, no neurological symptoms in the arms, and they also don't have symptoms relating to cervical myelopathy, the patient just has got neck pains with occipital headaches, that patient then would then benefit, that patient then would then benefit from conservative management in a form of physiotherapy, painkillers, and maybe possibly injections as well, but is not a candidate for surgery. But a patient who has upper limb symptoms in terms of the nerve compressions, those are patients who respond well to surgery. And then when it comes to so scaling the pain, if a patient tells you that my neck pain is a 4, but my arm pain is a 9, the pins and needles on my hands is a 9, that's most likely the patient who is going to benefit from surgery. That patient would need an MRI and then a diagnosis, a confirmation of the diagnosis made, and they probably would do very well with surgery, because the reality is that the nerve compressive symptoms, patients who have nerve compressions, they don't do very well with physio, painkillers, and all these other things. Surgery is the one that tends to give them the relief that keeps them going and that gives them that quality of life back in their lives. And the similar thing when it comes to the lower limbs as well. If they have back pain, how bad is their back pain? Rate in a scale of 0 to 10. If the back pain is stronger than the leg pains, then that patient would need is a candidate for conservative management. Where a change would be an exception to that is if they have back pain, they don't have leg symptoms, but they have features, they have instability features. That you will see it on X-ray. How will you see instability features? They're going to have translation of one vertebra over the other, what we call spondylolisthesis. If they have spondylolisthesis and they have back pain, that patient might be a candidate for surgery, depending on how bad the instability is, or the grading of the translation forward of one vertebra over the other. And the long-term effect of that is that it eventually compromises the canal, and it can cause spinal stenosis as well. So a patient who has back pain alone with no leg symptoms would do well with conservative management if they don't have features of instability, and they don't have spinal stenosis symptoms. If they have leg symptoms, that patient is going to be a candidate that will do quite well with surgery, for the same reason that nerve compressions, when it's advanced, it doesn't respond to anything else. It doesn't matter the position, whether you're lying down, you're sitting, standing, and it can be very, very debilitating for patients who have it. When it comes to red flags, it's important to consider that you might be dealing for spine. We should be worried about people who use drugs, your IV drug users, because they might be having abscesses because of these injections they're giving themselves. Excuse me, but also an infection to worry about in the spine is TB. It's a very common infection in our country, but if you're not thinking about it, you're going to miss it, or diagnose it too late just because you were not thinking about it. Tumors are very important. What I want to mention when it comes to tumors is, if you have a patient that you're thinking you might be dealing with a tumor, if they don't give you a history that they've had a diagnosis of some sort, and it was confirmed that they have this type of cancer, if there is a suspicion that they're losing weight that can't be explained, the symptoms are getting worse, the quality of life of the patient has been altered significantly, and you worried that something is gone wrong. They even are losing renal function is deteriorating, and they are anemic as well, and so forth. Now, you have to ask yourself, if they have back pain, where might this tumor be coming from? Because it could be that they have a primary tumor in the spine, or they have a secondary tumor in the spine. For spine tumors, you have to think about multiple myeloma being the primary tumor in the area that can give back pain. The typical thing about multiple myeloma is that it's going to be paining everywhere. They have bone pains in this. They have pains in their heads, in the neck, in the lumbar spine, in the femurs, because multiple myeloma is bone everywhere. So that is not a typical bone pain that they would just say it's in the spine. It's localized in the spine. Yes, they can have bone pain localized in the spine only, or that seems to be localized in the spine, if they have these lytic lesions and they've developed what we call a pathological fracture. A pathological fracture will make the pain worse at a specific point, and it might become a distracting level, and then they ignore or don't tell you about the pains that they have in their heads or in the pains they have in their femurs, because they might think it's not related. Meanwhile, it might actually alert you. Why do you have pain in your head? Why do you have pain in your spine? Why do you have pain in your hips? This patient might be having multiple myeloma with all of these lytic lesions, and you might miss it. Also, it could just be a metastasis that has gone into these different areas, which is lytic in nature, and the patient is at risk of having fractures. If you pick it up early, you might be able to get the patient the treatment they need. So, with regards to tumors, if you think of it if you're looking at it from your neck downwards, which tumors in the body can go to the spine, metastasize to the spine? So tumors of the thyroid will metastasize to the spine. Tumors of the breast will go to the spine. The lung cancers will go to the spine. Bladder, as we go down. Kidney tumors, colon cancers, and in males, prostate cancers. So thyroid, breast, lung, colon, kidneys, and prostate in males. Those are cancers that should come to mind if you're worried about metastasis to the spine being the cause of the patient's pain. So those are the areas you need to investigate if you're worried about a tumor that has metastasized to the spine. And then in terms of trauma, patient will tell you that they've had some kind of an injury, and this is why they have the pain that they have. If there's no history of trauma, then you have to look for reasons why do they have pain. If there's a history of trauma, now you want to find out, is this an unstable spine or is it a stable spine? If it's a stable spine, we treat it conservatively. If it's an unstable spine, we treat it surgically. We do stabilization and fusions. And then when it comes to the Coda-Equina syndrome I've mentioned above, it's amongst the emergencies in spine, this is the biggest emergency in spine, the most true emergency in spine. Anyone who's diagnosed, if you make a diagnosis of a Coda-Equina syndrome, you don't sleep on it. You don't sleep on it. You take the patient straight to theater and you decompress that patient. Because the outcomes tend to be dependent on how soon you decompress them. Those that get decompression within the first 12 hours do better, and those who get decompression after 24 hours, they don't do very well. And the sexual function as well as the bladder function tends to be very bad, and it doesn't recover very well. Even after the decompression has been done, you find that 6-7 years later, the functioning of the bladder is still not normal. Yeah, so it's a debilitating condition to have, and therefore you don't want to miss it if in a patient. So every patient you see, think of Coda-Equina and ask the symptoms. Any change in your bladder, bowel, and sexual function, any loss of sensation around the perineal area, as if you've been sitting on a horse. These things will guide you that you're probably dealing with a patient who's got Coda-Equina syndrome or not. The extremes of age, the very old patients and the very young. The very young patients, any child that presents to you with back pain is never caused by a heavy backpack. You have to consider that so every child that's got back pain is pathological until proven otherwise. So you have to look for reasons why they have back pain. And every child that's got a back pain with or without neurology should be investigated. And one of the investigations that the child should have is to get an MRI. It will help you with a lot of that information, because X-rays on their own, they might miss a lot of information, which might explain why the child has got back pain. And then in terms of the extremes of age, the elderly patients, if they've got pains in their back, we have to worry about vertebral compression fractures. But the biggest concern is the malignancies, be it primary or secondary, but most likely in the elderly patients, you would then worry about the metastasis. Now, metastasis coming from where? The areas I mentioned above, your prostate, your colon, your kidneys, etc. And then in terms of the unexplained weight loss, are you dealing with TB, are you dealing with malignancy? It's very important. Don't underestimate anyone who tells you that they're losing weight. If it's not intentional, you have to worry about the weight loss, unexplained weight loss. Anyone with neurological symptoms, you have to investigate, get the MRI done, see what might be causing the neurology, and then that patient will need to be treated accordingly. IV drug users, important because they're at risk of having infections, and those infections can involve the spine. Abscesses in the spine, and the treatment is different. When it comes to imaging that you need for these patients, X-rays, the patients who benefit from X-rays, everyone who has back pain does require an X-ray to make a diagnosis. The X-ray will give you useful information, and then now some of the colleagues might say, when do you want to do an MRI? When is it okay to just do an X-ray? A patient who has back pain with no neurology, or neck pain with no neurology. And when I say no neurology, I'm also referring to the symptoms relating to spinal stenosis. If they have no symptoms relating to spinal stenosis, and there's no features of instability in terms of the complaint, and they don't have radiculopathy in the upper limbs or lower limbs, it's just pain in the neck or just pain in the back, the X-ray of the area that they're complaining about tends to be adequate. It will show you whether there's facet degenerations or whether there is some narrowing around between the vertebra, meaning that there is a disc pathology. But if it's not symptomatic, it doesn't help sending a patient for an MRI if they have no symptoms. If it's just a neck pain alone, X-ray is adequate. If it's just a back pain alone, X-ray is adequate. But if they have neurological symptoms, then you add the MRI. And then when it comes to CT scan, those with trauma would require CT scan so that you can stage the injury, classify the injury, as well as assess whether the injury is stable or unstable. The MRI also does give you the useful information in terms of classifying the injury as being stable or unstable, in terms of, is there posterior ligamentous complex injury involved or not, if it's a trauma, because then a CT scan would not show you the posterior ligamentous complex injury, but an MRI will show you that. But a CT scan will show you that the bones are opening up. Then you can infer and say, if the spinous processes at one particular level are wider than the levels above and below, it means that level, there is a lot of destructive forces that acted at that level, and it tore up the posterior ligamentous complex. You can infer that, but it doesn't necessarily mean you can't do an MRI. You can do an MRI if you're in a setting where an MRI is available, and it will confirm that there is posterior ligamentous complex injury. If the patient has got that patient needs to have stabilization done for them, and to protect the spinal cord and reduce the risk of spinal cord injury. Bone scan, if you're dealing with unexplained bone pains in a patient, and not only just localized to spine, a bone scan will help you with that. And then in terms of DEXA scan, some of the patients who come for consultations are elderly patients, and these are patients who are at risk of getting vertebral osteoporotic fractures. DEXA scan will come in here, and you can see how osteoporotic they are. And if they are osteoporotic, then you can then refer them to rheumatologists and so forth for treatment. They might need to be started on bisphosphonates if they are osteoporotic by definition in terms of the DEXA scan. And then when it comes to just going into in a bit more detail with regards to the MRI, MRI is a gold standard in terms of investigating investigating spinal cord related complaints. MRI will show you everything. What's happening with the nerves, what's happening with the spinal cord, what's happening with the facet joints, what's happening with the discs, what's happening. It shows you everything. But the problem with MRI is that MRI should not be used alone. It should be used in conjunction with the patient's presenting symptoms and clinical findings on examination. An MRI, it reports information that you sometimes don't even need to act on because the patient is not symptomatic. So information that you get on MRI, you have to tie it with the clinical, with the presenting symptoms of the patient, not in isolation, because if you were to do MRIs on most people, you'll be surprised how many MRIs will come back abnormal, but the patient has no complaint, he's completely fine. Yeah, so the MRI is a gold standard. If you've got a patient who's complaining and they've got neurological symptoms or spinal stenosis symptoms or features of instability that you've seen on X-ray manifesting as spondylolisthesis, an MRI will come in handy in terms of giving you further information that will help you guide your management as well. In terms of your differential, when it comes to the neck and arm pain, you have to think of trauma. Have you been injured, car accident, and so forth? That might explain why you've got pains in your neck. Is this a patient who might be having metastatic disease into the neck? Excuse me, is this a patient who has radiculopathy symptoms? If they have radiculopathy symptoms, they probably have this pathology manifesting as a radiculopathy. Because the disc pathology, what it does is that when the disc bulges, it bulges in the direction of the spinal cord and nerves. And if it bulges in the direction of the spinal cord, it will give you, if it's significant, it will give you spinal stenosis. If it bulges in the direction of the nerves, then it will give you nerve compressive symptoms, which is the radiculopathy. So on its own, for the majority of patients with radiculopathy symptoms, the culprit tends to be the disc. The disc has probably prolapsed and is putting pressure on the nerves. And then ankylosing spondylitis. If you're not entertaining this, if you have a patient who seems to be very stiff in terms of how they're talking to you, there's very little neck movements in terms of rotating to the side or using the head movements when they're talking to you, you should worry that you might be dealing with this as a patient who's got ankylosing spondylitis. Especially if it's a younger patient, someone in their 30s, 40s, you might be dealing with ankylosing spondylitis. The elderly patients, that's the group that where a condition that we call DISH, where we see most of those patients. But in younger patients, you have to worry about ankylosing spondylitis. And this, we're going to see it on X-ray. It looks like a bamboo spine. If you see anyone with what looks like a bamboo spine, be it in a lumbar spine, be it thoracic spine, be it in an inner cervical spine, we might be dealing with ankylosing spondylitis. And if you don't think about it, you might not investigate it and make the diagnosis, or request an X-ray when it's actually needed to make the diagnosis. When it comes to cervical myelopathy, we've mentioned it. This will manifest with patients feeling like their hands are clumsy. They have difficulty just opening and closing bottles. Becomes very difficult for patients that have cervical myelopathy, and the walking gait pattern worsens, becomes difficult. They are stiff. Those are the features that should alert you, and they have got brisk reflexes and increased tone, that you're probably dealing with someone who's got cervical myelopathy. And if you have those symptoms, you need to have an MRI done so that you can make the diagnosis. Where is the compression? How bad is the compression? What needs to be done in terms of treatment to help with the symptoms? Is there a cord signal or not? So that when you're discussing the treatment options with the patient sort of understands that they may have left the compression a bit too late, because now there's already a cord signal which indicates that the outcomes might not be as favorable even after the decompression. The cervical spondylosis, this one will just manifest as neck pains, but with no neurology. But if there is radiculopathy, then you have to think you might be dealing with a disc pathology as well. That's causing the compression onto the nerves. One of the symptoms to bear in mind in patients with cervical spondylosis is that they will tell you that they get occipital headaches. And this has got to do with the attachment of the muscles. So when they've got muscle spasms, they will tell you that they're getting tension headaches, occipital headaches. And then when it comes to if a patient tells you they've got pains in the neck, those are your differentials that should go through your mind. If a patient tells you that they've got thoracic pain and rib pain, and now what should you be thinking of? Is this a patient that's been involved in some kind of trauma? If not, are you dealing with a thoracic disc herniation? The disc herniations are commoner in the cervical spine because the section, that part of the spine, is not as rigid as the thoracic spine. Thoracic spine is rigid, so there's very few disc-related problems in the thoracic spine compared to the neck as well as the lower back. So the mobility of the spine puts the spine at risk of having disc desiccation and disc prolapses. So thoracic spine is a cage. It's a much more rigid section of the spine, and that's why a majority of the patients who get injuries in that section of the spine, we are able to treat them conservatively because it's an inherently stable section of the spine. So to have disc herniations is uncommon in the spine, but you have to think about that if you've got a patient that has got thoracic spine pain, because it is a condition that you can get. And it can also cause compression of the spinal cord, and it will manifest as upper motor neuron symptoms in the upper thoracic, if it's in the thoracic spine. When it comes to the other causes, why would someone have a compression fracture? It would have a back pain in the thoracic spine. Think of osteoporotic compression fractures, especially in the elderly patients, but also in patients in whom you're worried about metastasis, or those who have multiple myeloma. They can get compression fractures in the spine, which can cause them a lot of pain. The other condition to think of is metastatic disease, as we've mentioned before. It can affect the thoracic spine, and it can cause patients a lot of pain. And then the infections, TB being a big infection that is common in the thoracic spine. If you've got a patient with the thoracic spine pain, please do consider TB, because it might be just what the patient has. And the nice thing about TB is that it responds to treatment very well, even in the thoracic spine. In the spine, TB responds to treatment very well. And if it's picked up early before they develop the deformities from the bones collapsing onto themselves, if you pick it up early, they don't need surgery. They just get the treatment and it heals, and then the patients are fine. But even if it's picked up late, TB of the spine generally responds quite well to treatment. They may or may not need a surgery to stabilize to basically correct the deformities and protect the spinal cord if the spine is now at risk of being injured because of the deformities. And then for lower back pain, what one should think about there, am I dealing with muscle sprain? Is this a lumbar spine osteoarthritis, the so-called lumbar spondylosis? If it's lumbar spondylosis alone with no neurological symptoms, that patient will just benefit from physiotherapy, painkillers. The reason I'm mentioning physiotherapy, painkillers is intentional because before patients are put on painkillers, we should actually be sending them for physiotherapy, because a lot of these patients don't necessarily have to take painkillers. So the problem with painkillers is that we're very eager to prescribe it, but painkillers have got side effects. So if you can treat a patient just through physiotherapy without giving them painkillers, that's better than just starting a patient on painkillers and then not even referring them to physiotherapy and then hoping that the patient will just take painkillers forever. And you know that the painkillers are not innocent, they've got side effects. So we shouldn't be too eager to prescribe painkillers, but we should also be looking into what else can help the patient so that they don't have to take so much painkillers and be dependent on painkillers. Degenerative spondylolisthesis, I've mentioned this, the problem with this being the pain in the back, and that it can also manifest as a spinal stenosis in advanced stages. And this generally would require surgery at some stage. depending on the degree of translation. Spinal stenosis, very important. In patients that have spinal stenosis may need to have surgery to decompress the spine. And if it's severe, these patients actually do quite well if the areas around the spinal cord have been opened up, and they recover quite well. The prognosis is quite good if you take away the stenosis. And then the lumbar radiculopathy, if they have lower limb symptoms, you have to investigate these patients, and you have to then assess how bad the pain is. The ones who have chronic compression of the nerves and it's not improving but worsening, those are patients that might be candidates for surgery to decompress and improve their symptoms. When it comes to disc herniations, the central disc herniation will compress the spinal cord and it will present as spinal stenosis. If it's paracentral disc herniations, meaning on the sides, what lies on the sides is the nerves, and those are patients that will then present with lower limb symptoms. So when it comes to the disc herniation on its own, it's not a problem. The problem is what effect it has on the spinal cord and what effect it has on the nerves. There is a lot of patients who walk around with disc herniations and they're not even aware that they do have. And then when it comes to abdominal aortic aneurysm, this I'm mentioning it because it's a condition that might be easy to miss if you're just not thinking about it. Excuse me, abdominal aortic aneurysm is a differential. It's not a cause of back pain as such, but more of a referred pain. And if you manage to pick it up, then you can refer this patient to vascular surgeons, and this patient you may save this patient's life. Because if this aortic aneurysm does rupture, eventually this patient might demise. So if you're not thinking about it, you will miss it. So even when you're doing the investigations and your MRI and so forth, if they mention an aortic aneurysm, probably instead of just focusing on the disc is normal, the nerves are compressed and so forth, if they've mentioned an aortic aneurysm, possibly it's better to just refer that patient to a vascular surgeon so that they can assess and see, does this patient need some kind of intervention so that the patient doesn't end up with a worse off outcome, which is when it ruptures. And if it's in the sacroiliac area, I think of ankylosing spondylitis is one of the conditions we mentioned. We're talking about it when we're talking about the neck. In the sacroiliac joint as well, these patients get pains in that area because of the ankylosing spondylitis. And if they have infection in the area, that can cause pain as well. And then if patient complains of pain in the sacral area, then it could just be the pain originating from the sacrum, coccydynia, or it could be that they have a fracture in the sacral area, what we call sacral insufficiency fracture. And this generally would respond well to treatment, conservative treatment. They might need a donut where they sit on it to take the pressure off the fractured area. And then once the area has healed, the pain will improve and the patient might not need to use the donut to sit on it. So in terms of the treatment, it's always important to understand the difference between conservative treatment and surgery. So there is no condition in spine where you say this is only treated by surgery or this is only treated conservatively. There is an overlap between these different conditions. And it's in the early stages, they might be amenable to conservative treatment, but in the late stages, they might be amenable to surgery, even though the condition is still the same. So it's a spectrum. In terms of the conservative treatment, here we're talking about physiotherapy, and I'm mentioning that first before analgesia, as you can see. The analgesia and then the injections. The patients who've tried physiotherapy and analgesia and it's not really helping, they might benefit from having injections. But also the injections I'm referring to, we're talking about facet injections as well as the rhizotomy. Rhizotomy, be it in a form of open rhizotomy or in a form of radiofrequency ablation, where we just put needles and then we increase the heat signal and it burns the tiny nerves, middle branch nerves that supply the facets, and then it takes away the pain. So the facets in the lumbar spine contribute significantly to the pain that the patients will present with. So for a lot of patients, they present with a disc prolapse or disc. So it's a disc that is desiccated, meaning it doesn't have enough water in it, which then fails under compressive forces and it bulges sideways and backwards, which then creates the series of symptoms that the patient will present with. Is it compression of the spinal cord? Then it's going to be spinal stenosis. With compression of the nerves, then it's going to be radiculopathy in the lower limbs. And then, so if there is a disc problem, which is the problem in the lying in the structures that are in front of the spinal cord, the body then uses the structures that lie behind the spinal cord. And those structures that lie behind the spinal cord is your facets and as well as your ligamentum flavum. So if there is a problem with the disc, the body responds to that by using facet joints a lot and also by thickening the ligamentum flavum. So what then happens is that these patients end up with a thickening of the ligamentum flavum, what we call ligamentum flavum hypertrophy, as well as thickening of the facet joints, what we call facet joint hypertrophy. The problem with these changes is that when they become bigger, the facet joints as well as the ligamentum flavum, they also encroach in the direction of the spinal cord. So now you've got compression coming sideways from the facets and the ligamentum flavum, as well as from the front coming from the disc that is prolapsing and bulging backwards. So this is what ends up causing the patient to have spinal stenosis. And so what I'm basically saying there is that the facets are quite a big culprit when it comes to the amount of pain that these patients will be having. So doing facet injections, a lot of these patients tend to respond quite well. And then if they respond well to the facet injections, then they are candidates for rhizotomy. Rhizotomy works very well. It works for patients. It gives them pain relief for a year up to 2 years. But medical aids, they prefer that we start off with the facets. So generally, patients would then have facet injections first. If they respond well to the facet, then they can then have the rhizotomy. The nice thing about the facet and the rhizotomy is that it reduces the need for the patient to be too dependent on painkillers. Because patients will tell you that painkillers give them a lot of side effects. And if there is a way of treating back pain without being on painkillers heavily on a daily basis, that is better than being heavily on painkillers. So these are treatment options that work quite well for patients that have isolated back pain with no lower limb symptoms. And then when it comes to surgery, so surgery that's done for patients with back pain, it could just be decompression alone, could be decompression and fusion, or it could be fusion alone. So decompression alone, fusion alone, or a combination of the two, which is a decompression and fusion. In younger patients, we would go for decompression alone. In patients that have instabilities of the spine, they would get fusion with no decompression if there is no compressive symptoms, but you want to stabilize the spine. And then patients who have problems with the facets and the disc, and there is compression of the spinal cord and compression of the nerves, those are patients that would benefit from decompression and fusion to take away the movement of that joint, because the pain that we feel in our joints is as a result of the degeneration of the joints. So the joints in the spine, what some patients might not, or even us as doctors, we might not be aware of, is that the facet joints are actually joints in the body. Just like all the other joints, your hips and your knees and your shoulders, they degenerate, and they, just as much as you're going to degenerate your hips and your knees over time, and then you need replacement. The same thing is happening to your spine, because your spine is carrying you everywhere you go, everything you do, the amount of movement that we subject our spines to. These joints, small joints in our backs, they're bound to degenerate and then give us pains as well. So the facet being the big culprit, it responds quite well to facet injections, as well as the rhizotomy in the early stages. And then in the late stages, If there is associated other compressive symptoms, spinal cord and nerves, then patient might be a candidate for surgery if the conservative treatment has failed. So who benefits from surgery? There we're talking about those with lower limb symptoms, especially if the patient tells you that they have very strong leg symptoms, but very minimal back pains. That's a patient who's got significant compressions of the nerves, would benefit from surgery. If they have instabilities as a result of the infections like TB, they would benefit from surgery if the spine is at risk of being injured because of the instability. Be it instability coming from fractures, that patient would benefit from surgery in a form of stabilization. Patients with spinal stenosis, which is significant in affecting their quality of life, would benefit from surgery. Those with cervical myelopathy who are symptomatic, they do quite well if they don't have cord signal yet. Their response tends to be quite good. If not left till it's too late. So cervical myelopathy does reasonably well after the surgery if it's picked up a little bit early. And the deformities, be it coming from the infections like TB or scoliosis that's causing a patient the pain and the discomfort. These are patients, especially for scoliosis, when they have the angulations of the spine with the degree being over 40, the corpse angle being over 40. These are patients who tend to do well. So the thing with, just to touch up a little bit on scoliosis. Scoliosis on its own normally is not painful, especially the one that we call adolescent idiopathic scoliosis. So if you have a patient with adolescent idiopathic scoliosis who complains of pain, you have to look for a reason why do they have pain, because normally it's not painful. The majority of the patients who get the surgeries done is for cosmetic purposes, meaning to make the spine straighter because they don't like how it looks, because their friends make fun of them. And also the other advantage of having the surgery done, other than just the cosmesis, is that the scoliosis, even so, the adolescent idiopathic scoliosis, it starts around the age of 10 and it continues until they reach skeletal maturity. The problem with scoliosis is that it doesn't only stop when you reach skeletal maturity. The angulation still continues at 1 to 2 degrees every year. So now, if you are a patient who has an angulation of 20 degrees when you are 20, and then if you're going to live 40 years, you're going to have to add 40 to the 20, you are now at 60 degrees. So now when you are an elderly patient, your spine has angled itself so much, has rotated so much, that it's giving you so many problems, which at a younger age, you were told, no, you don't need the surgery at this stage because your angulation is 20 degrees. But we know that this worsens over time and it rotates. The spine continues to rotate and worsen at 1 to 2 degrees per year. And these patients, they complain of these very debilitating symptoms later on when no one is going to touch them. Because if you've got scoliosis and you are now 70, 80, there's no doctor who's going to agree to operate on you. But you find that if the procedure had been done at a younger age, this person would have had a normal quality of life. So it's one of those things. If a patient has got scoliosis, don't just assume it's okay just because they're still managing. Sometimes as they get older, they really struggle. So it's better to have a spine surgeon have a look at what's happening and then make a decision. In terms of the bracing that we use for scoliosis, they don't reverse the condition, they just slow down the rotations. So some of these patients will start off with bracing and then may end up with surgery as well. And then when it comes to the other treatment for these conditions, it's if you're dealing with a patient who has failed conservative treatment, then there's no other option but to consider surgery. So one of the indications, if a patient has tried everything and it has failed, this is a patient who would then benefit from having surgical treatment. What I wanted to touch on a little bit as well, when it comes to the surgery. There is a lot of talk around surgery, which is not true. People around the streets, they keep telling people, surgery is bad for you, surgery is bad for you. Please, colleagues, let's not tell patients that surgery is bad for them and then subject them to painkillers for the rest of their lives and instill fear on these patients when there is something that might be offering hope for them. So some of these patients, they actually do quite well with surgery. A lot of these patients do quite well with surgery. It's just that the surgery has to be picked closely to benefit that particular patient. The indication for surgery has to be adhered to. This is the reason why I need to do the surgery on this particular patient. And these are patients who respond well to treatment. But they will not come and entertain the idea of surgery if we keep on telling them that they're going to be paralyzed, they won't be able to walk, they're going to be, let's not instill fear. Let's mention the treatment options. We can treat you conservatively, but surgery may be needed. It's not as bad. The surgery is not as bad as it's made out to be. If it's done for the right reason, it might be a life changer. It might be a game changer for you. There are patients who get their lives back just because they've had surgery. And they even regret listening to people on the streets. I get some patients who tell me, Doc, you know what? The people around me tell me that I must not do surgery. So what I'm going to do is when I come to do my surgery, I won't tell anyone. I'm just going to come and get my surgery done. And then afterwards, then I say, okay, I've had my surgery done. Because they keep on telling me, don't do this, don't do that, don't do this, don't do that. It's because of what we tell them. Let's not instill fear in our patients because surgery is sometimes a game changer for these patients. So I'd rather have them assessed by a spine surgeon to see if they would benefit from surgery. But don't be the reason why someone is struggling to cope with the activities of daily living, why they are so sad in their lives, why they're basically making everyone around them miserable because they are in so much pain, just because you are telling them they can't have surgery because they're going to be paralyzed, or you're saying all the bad things about surgery. I'm not saying surgery doesn't have complications. There are complications, but the complications are managed, and sometimes if the patient says, I have suffered and I've tried everything else, surgery is a viable option and sometimes might just be the best option for the patient. And it gives them hope as well, rather than just knowing that it's all hopeless. You're just lying at home, you're doing barely nothing, you're just taking painkillers and waiting for, I don't know what, God knows what. So that's one of the important things I just want to mention. Colleagues, let's please don't scare our patients when it comes to surgery. If they need surgery, the surgery would benefit them. A surgeon would make that decision to say, should I or should I not? But don't be the reason why a patient is suffering because you told them they shouldn't have surgery, please. All right, thank you very much. And that's it from me.
Thank you very much, and Dr. Zondo, I think, for a wonderfully delivered presentation on a very common topic, complaint that doctors see at all levels, general practitioners, specialists, not only orthopedic surgeons, but orthopedics from different clinical disciplines come across this problem of back pain, and I think you've covered it quite well. But maybe let's do questions first. And there are a number of questions that have been posted in the chat group that I've noticed. You can switch your camera on, Dr. Zondo, so that people can see you and recognize you when they see you next time, if you don't mind. Let's start with the hand. I think Dr. Charles Mujagashi, you've got your hand up. People can raise their electronic hands, but they can also post the questions in the chat group. So maybe let's start with Dr. Mujagashi because his hand is up. You can unmute yourself, Doc, and go and ask your question.
Can you hear me?
Yes, we can hear you quite clearly, Doc.
No, thank you very, very much. I just wanted to say thank you to Dr. Zondo. Thank you very, very much for a very, very good presentation. I am reminded, disclosure, I'm not a spinal surgeon. I'm doing other things in orthopedics. I'm reminded about 20 odd years ago at September, I had to do an in-person presentation on the management of backache. Let me say that your presentation today was streets ahead of anything I tried to do. Be that as it may.
Thank you so much.
Professor Tsitsi Merek often talks about the art of medicine. And I think what you alluded to in this instance is precisely that, the art of medicine. That when somebody presents to you with backache, you need to begin in an open-ended fashion to try and get a feel of what they're trying to tell you and where the conversation is going, because it's so multifactorial.
Yes. Yes.
I just want to say thank you. That's all.
Thank you so much. Thank you.
Thank you very much, Dr. Mujagashi. Let's start with the first question. I think it's from Dr. Sotetsi, who says, how would you differentiate meningeal paresthetica from spinal issues?
So that's a condition I don't deal much with, to be honest, the meningeal paresthetica. The thing is with spine, when it comes to conditions affecting the spine, if you have a patient that is presenting with neurological symptoms in the lower limbs, now you have to ask yourself, is this a patient having symptoms in the lower limbs because they've got they have compression of the nerves in the spinal cord, or is it because there is a condition that is affecting their nerves, be it in a form of vitamin deficiencies and so forth, or any other conditions that affect the nerves, be it viral or any other cause. So if you have a patient that has got unexplained pains on the lower limbs, and then you now have to look for reasons why do they have neurological symptoms in terms of paresthesias in their lower limbs, but there is nothing else that can explain. The spinal cord is basically the MRI of the spine is normal, and you can't explain why this patient would have these paresthesias. Then you now have to look for what might be causing this. What are the vitamin profile of these patients doing? Can this be explained by that, or is there any other cause that might be viral in nature, or any other cause that might explain why the patient has got the symptoms that they seem to be presenting with? It's not a condition that I see much of. Majority of the patients that I tend to see are patients that have got quite a lot of compressive symptoms. And sometimes even patients that come and present very late in the disease process, for part of the reason being the fear of knowing what is the problem and what might be offered as a treatment.
Okay, thank you. There's a question, I just want to check from who. I think it's also from Dr. Zotet, who said, we refer all patients with back pain plus narrow disc spaces without without any other symptoms. I think it's just a statement. Would you refer, should we, okay, that's a question. Should we refer all patients with back pain and with narrow disc spaces without any symptoms?
I would say my suggestion there is that yes, do. And I will say why. The reason why I would say do is, unless you are comfortable doing the injections, the so-called facet injections or rhizotomies, which normally the neurosurgeons or the spine orthopedic surgeons would do, the aim is not to keep the patient on pain, because what you're going to see, patient presents with pain with a backache, and now you start them on painkillers and doing physiotherapy. But if that doesn't help, your next treatment will then be to see if this patient would benefit from having the injections. So if they come and they see me and you've done the x-ray, but they don't have all these other lower limb related symptoms, now I'm just dealing with a patient who's got backache, narrowing of the disc space, as well as back pain. So this is a patient that I can then offer an injection, which will then reduce the need for this patient to be on painkillers. And even the quality of life also improves. They start being more independent. They start being able to do a lot more and just be happier in general. So much so that some patients would come on a wheelchair, they have the injections done. It's not surgery, nothing magical, just they've had just the injections alone. And then all of a sudden they're able to walk around, they're able to get some independence back. So I would say, yes, please do, especially if it's someone that you've seen, let's say 3 months, 6 months, and you've given them painkillers and you can see the problem is persistent. And we can't continue just giving painkillers because we're increasing the side effect profile as well. Some of these painkillers, the side effects, they worsen over time. The longer you are on them, now you're getting ulcers and kidney problems and so forth. So I would suggest that the patients with chronic back pain, do refer them to a spine surgeon so that they can be assessed to see, do they need anything more than the physiotherapy and painkillers, and what else do they need? Because sometimes if we just keep giving them the painkillers and the physio, we sometimes miss certain changes, subtle changes that happen in the spine, and to find that the patient comes to you, now things have changed. Because the thing is, with the disc, there is what we call an acute Cora-Equina syndrome, where the disc pops and then you get acute compression of the spine. But some patients have got this chronic Cora-Equina syndrome, where the compression has been there slowly, it's been brewing slowly over years, but no one is picking it up because maybe the questions were just not directed in that line of thought, and therefore it gets missed, and it is just an assumption that this person has got problems with the urination, he's a male, it's probably just it comes from the prostate, and so forth. So sometimes the spine surgeon might pick up certain subtle clues that might just might change the diagnosis and might also change the treatment for the patient and optimize the treatment for the patient.
Okay, thanks very much, Doc. There are quite a number of messages in the chat group. Some of them are questions and comments, but a lot are saying how excellent presentation it was, and very straightforward, easy to understand. And I think they're quite grateful. But there's one question. It says, you said all patients with back pain need x-rays. Shouldn't we try treatment first, especially when thinking of non-spine causes?
So if we try treatment first, but we don't know what we're treating, what are we starting the treatment on? What are we treating? Are we giving them painkillers? Are we giving them physio? What are we treating? Because if we don't have an x-ray on someone who presents to you with a back pain, you basically don't have any guidance as to what might I be dealing with. If you do the x-ray and it's normal, now you're thinking, okay, then it means I might not be dealing with a spine problem here. It might be referred pain. If it's referred pain, where is it coming from? Is it from the aorta? Is it coming from the kidneys? Is it coming from the what is the so-called what do you call them, ovarian cysts and so forth, gyne related kind of problems?
Okay, there's one, Doc, which says that what's the cause of lower back pain on one side aggravated by bending forwards?
So the bodies have got two facets at each level: left side, right side, left side, right side. The degeneration of the facets tends not to be the same for all the patients. For some, the degeneration is on one side compared to the other side. So if the degeneration is more on the left compared to the right, you're going to feel pain on the left. And then how that will then manifest would be the pain like we were just mentioning now. When you're leaning forward, movement around the spine, leaning forward, standing up straight, rotating your spine, what moves this facet will now give you the pain. And then when you're lying down, you find that the pain is much better because it's originating from the facet. So when you're lying down, you're not moving the facet, but if the pain is worsening when there is movement, you're probably dealing with a facet if it's centered on one side of the spine and not on the other. But sometimes you do get pains that's centered on both sides of the spine, the left and the right, if there's equal degeneration of the facets on the left as well as on the right.
Okay. Dr. Mohideen Khan says a 58-year-old losing muscle mass around the buttocks, and the patient is on L-toxin and also has dyslipidemia on treatment. The patient has got recurrent backache. We don't know whether it's a female or male. He has got recurrent backache, has consulted a neurologist and an orthopedic surgeon with no relief for the past year. Is now having difficulty walking. Besides low backache and buttock pain, the x-rays were normal. Obviously, the candidate has got needs an MRI. It's a candidate for MRI, the patient, but financially keeps deferring going to province. I suppose it means a state hospital, a provincial government hospital. What would you advise?
So unfortunately, it's a patient that would benefit from the MRI. It would give a much more accurate information as to the status of the spinal cord. My feeling is that the MRI will show that the spinal cord is compressed. Now, the other thing to think about is there a spondylolisthesis at the level of the compression, which might be causing this patient to be in pain and difficulty with the moving around or walking around. So the X-ray on its own, sometimes if you look closely on the X-ray, you are able to see the defect the fractures in the pars interarticularis for patients that have got spondylolisthesis. But sometimes if it's in the early stages, it's difficult to see, it's subtle, you can easily miss it. Because if there is a defect in the pars interarticularis, it would explain why there would be a subtle translation. The MRI, though, would be quite useful in terms of making the diagnosis is there, because if there is a fracture there, the MRI will light up in the area where there is a fracture. And then you know that, okay, even though the X-ray showed no fractures of the pars interarticularis, but MRI highlights that area that there is a defect there, so there is a fracture, which would explain possibly the reason why there might be translation at that level, or there might be spinal stenosis at that level. The government hospitals, I am aware that it is difficult to get an MRI. The waiting list can be very long. Sometimes it can be years. And the problem with private is that the funds, medical aids, a lot of medical aids tend to tell patients to pay out of their pocket when they need to get an MRI done. Even though the MRI for this particular patient sounds like it might be a game changer in terms of getting this patient the treatment that they need. So what I sometimes do to help patients with this kind of a problem, if I feel the MRI is indicated for the patient, I write a strong motivation to the medical aid to say, I have this patient, this is the problem, and this is what I think might be happening with this patient's spine, but I need this MRI to make the diagnosis, which will then guide me the management that I can offer to this patient. Please authorize this MRI because it is important. So what I've seen is that some of the medical aids, even if it's not covered, the MRI, some do look into that, and then they make the necessary adjustments. You find that what they would then do is to come back and say the MRI is authorized, but the patient will then have a co-payment of 1,750. Now it's all of a sudden a lot more affordable to pay for the MRI, paying 1,750 compared to paying 10,000 or 11,000.
Okay, I would advise Dr. Khan to also refer the patient to one of the central hospitals in the provinces. I think all central hospitals in the country now have MRI scans. And if you know any of the orthopedic surgeons working there, to contact them personally. If you are the referring doctor, it helps at times for your patient. But there is a question from Dr. Desai who says, can cervical neck pain, well, if it's cervical, it's neck, is cervical neck pain cause stiffness and pain in the shoulders?
Yes, it can. So a lot of patients who come present, who have problems with the neck, some will tell you that if you ask, is there a problem with your neck? They say, no, my neck is fine. Okay, do you have irritation or pain around your shoulders? Basically pointing on the upper aspect of your of the shoulders. And then they'll say, yeah, I do get that. And then they don't relate that to a C4, meaning that there is a problem with the neck, and this is the irritation they're feeling on the shoulder is actually originating from the compression coming from the neck. So sometimes when you probe the questions, because now what also happens is that if you've got a strong back pain, but the neck pain is not so much, a lot of patients tend to just say, oh, I just thought it was because of stress. That's why I have irritation on my shoulders, or that's why I have stiffness on my shoulders, just thought it's because of stress. Meanwhile, it could just be because there is a problem with the spine, with compression of the nerves, when what we call a referred pain, radiculopathic symptoms causing the pain over the C4 distribution, which would then be around the shoulders, as well as the C5. The commonest areas in the spine where you get problems with the nerve compressions is your C5, C6. That's a very common area in the cervical spine. And then it can involve C4, C5, as well as C6, C7. Those are the commonest areas. So these are patients that will then have issues with the shoulders. But how you tell if someone has got, because you can also have stiffness and pain of the shoulder because there is an intrinsic pathology in the shoulder itself. But then if there is a pain, intrinsic pathology of the shoulder, what then, if you just gently hold the shoulder and just take it through rotations and just ask the patient to relax and say, does that movement cause pain? If there is no pain when you're moving the shoulder, you're checking it through range of motion, internal rotation, external rotation, abduction, adduction, and the patient says, no, there isn't pain when you do that. Chances are that patient does not have intrinsic pathology of the shoulder, but has got pain coming from the neck, which means that this patient has got neck pathology. And when you do an X-ray, you'll probably find that they've got facet joint arthrosis, as well as narrowing of the disc spaces, and just particularly at C5, C6, as well as it might also be at C4, C5, as well as C6, C7.
Okay, thanks. There are only two more at the moment. I think this is Dr. Kogoma, who's asking, can spinal stenosis occur acutely in a patient because they were moving office and she was carrying boxes of files? I think this sounds like one of the ones you mentioned in your presentation. But yes. Can you get spinal stenosis from moving files, from acute pain?
Yes. Yeah. Yes. So if acutely you're getting symptoms in keeping with spinal stenosis and you are moving house or carrying heavy things, most likely you've popped a disc. And then you've got sudden compression of the spinal cord originating from the fact that the disc has now been compromised. Because if you get a disc prolapse in the direction of the spinal cord, if it's central disc prolapse, it can then compress the spinal cord and then give you the spinal stenosis. And if it's severe enough, then it can also give you the Cora-Iguana syndrome.
Okay. Well, there's one which says an 8-year-old with severe sacral pain with difficulty in walking post a fall after falling, and with a normal X-ray, pain resolved after 3 days, should one be worried?
If the pain resolves after 3 days, I wouldn't be too worried. It's a positive sign. So if you've got someone who has had a fall and the pain improves and the X-rays are normal, the most likely culprit would be a disc. But if the pain is improving and you've not done anything else in terms of treatment, even if it's just the treatment you've offered is physiotherapy, but the patient is responding to physiotherapy, plus minus the painkillers, then that's a positive sign. A patient who's improving after 3 days of being on treatment or 3 days after the injury, that suggests that it's most likely not coming from the fracture, and it's most likely coming from the irritation coming from the disc. It's either a disc that may have been compressed, and then the body's response to that may have been muscle spasms, which will then cause the pain, which initially caused the pain and lock to the back, and then with the patient lying down and relaxing and getting physiotherapy, that tension improves and then the symptoms improve. That would be a positive sign. I wouldn't be too worried, but I would just follow the patient closely, see the patient at 6 weeks, see how the symptoms are improving, but keep an open door to say, if anything changes, please do feel free to come back. But the fact that you're improving over a period of 3 days is a positive sign, which means that things are getting better, but we just need to keep an eye on it.
Okay. Professor Dr. A.K. Desai says, the patient who had spinal anesthesia for cesarean section complains of persistent headaches. How do you manage this, Doc?
So persistent headaches after a spinal anesthesia, for me, I wouldn't assume that it's as a result of the spinal. If they have persistent headaches, now if you have the so my approach there would be to look for the reason why would the patient be having a headache. Is it because they've had the injection there, or there is another reason? And one of the investigations I would do would be an X-ray of the neck, C-spine. You might find that this is a patient who actually has got facet arthrosis with muscle spasms in the area, and is getting headaches. So patients tend to link the injections through their backs to the cause of pain. I see a lot of patients who will tell you, Doc, when I hit my child, they injected me in the back, and then since then I have a backache. But that's not the cause of the pain. Backache is not because they had the injection in the back. They're probably having the problem that they're having because of the pregnancy itself, and not because they had the injection in the back. But patients will not say, I have pain in the back because of the pregnancy. But we know that pregnancy on its own, because now you're front heavy, and then you're going to be using your back to arch your back more to keep yourself upright. And they tend to get a lot more backache during the pregnancy compared to when they are not pregnant. So sometimes the backache starts when they're pregnant, and then it persists. But they would then say it was because they had that injection when they were delivering. Meanwhile, it's actually something that's not necessarily completely related. So I would look for reasons why they would have a headache, and not necessarily blame it on the injection. Because if you have an injection in the spine, unless you've drained so much fluid, because I mean, when you're doing an injection into the back, you're doing a spinal. The amount of medication you're injecting there, it's generally a medication. It's generally medication that wears off, be it within the period of 12 to 24 hours. So now, if they have persistent headaches, why do they have the headaches? Is it coming from the neck, truly, which means it's completely unrelated, or is there something else? If it's related to the needle, then I would be worried. Could this be that maybe this patient has got an infection? But an infection in a patient that had the injection done in a sterile environment would be low on my risk. I would look for reasons why would they have the reasons outside of the injection itself because often than not, injection is not the reason.
Yeah, the questions are they don't stop. But what I would say is, we will send all the questions to you, Doc, because now we are over time. We normally go till 7:30, 19 hours 30. But just before we request Professor Velapi to do a quick vote of thanks. I think there's just one interesting one from all the other 3 or 4 questions that are there. I think we will email them to you, and I think the senders will get responses if that's fine with everyone. But there's just one interesting one from one of your colleagues that I think would assist a lot of other people. And then he lists a number of terms, spondylosis. I think there's muted. Can you mute? Thank you. There are quite a number of terms: spondylosis, spondylitis, spondylolisthesis, this one is the first time I hear it myself, I must admit. Spondyloptosis. I think spondylosis and spondylitis and spondylolisthesis, many doctors know that. But there's also spondyloptosis. And then they say, please clarify the differences between these words. Doc, are you able to just briefly deal with that?
So when we talk about spondylosis, be it cervical spine or lumbar spine, we're referring to osteoarthritis of the lumbar spine or cervical spine. It's just a fancy term that spine uses to indicate that a patient has got osteoarthritis of the lumbar spine. So we call it spondylosis, cervical spondylosis or lumbar spondylosis. Spondylolisthesis means that there is a translation of one vertebra over the other. And it's generally an indication that there is a defect. The structures that provide stability or that lock one vertebra over the other, being a pars interarticularis that is intact. A defect in that part of the spine allows the vertebra to translate forward. But you can have the vertebra translating forward even in cases where there's an acute fracture, and then the vertebra can translate forward. So the spondylolisthesis simply means that there is a translation of one vertebra over the other. Spondyloptosis means that the vertebra has translated. So if you've got spondylolisthesis, the vertebra translates over one vertebra translates forward over the other. This is less than 100%. So it could be 25%, 50%, 75%. If it's more than 100%, then you've got spondyloptosis, which is a complete translation of one vertebra over the other. Generally, we don't see much of that in normal population, except in patients that have congenital malformations in terms of the development of the spine, especially around the L5S1. There are patients who are born with deformities in that section of the spine, and then the vertebra just translates completely forward, and that's what we call spondyloptosis. What was the other one?
I think spondylitis, but I think that one, I suppose it's
an inflammatory process.
Inflammation,
in the spine.
Yeah,
inflammation.
That one is clear.
Yeah.
All right. Thank you very much. I think all the other questions, we will send them to Dr. Zondo, and Dr. Zondo will respond to. We have all your emails. I think you give us emails as you register. I'm going to ask Dr. Prof. Sitembiso Velapi. Prof. Velapi is the head of pediatrics and neonatology at Chris Hani Bara Academic Hospital, also Vets Medical School, University of Witwatersrand. He's also associated with Clinix on a spare time as one of the senior clinicians and academicians assist Clinix in their quest towards clinical governance. I think within Clinix Health Group, quality assurance and patient safety, I think, are prime. And as a result, we've got a number of clinical governance forums, and there's one we call the clinical risk group that has 6 academicians in our medical schools, in FEDS, UP, and SMU, who assist us in our clinical governance. So Professor Velapi is one of them, and he is going to do a vote of thanks for us. Please go ahead, Prof. Aviva, you can unmute Professor Velapi.
I've unmuted everyone, Doc, but let me just look for him and see if I can.
That's right. He is in the meeting. Okay, I see he's calling. Prof. You can unmute, yeah. If you just unmute.
No, he can't. Can you please try, Doc? Because I made it so that anyone can unmute themselves.
All right.
Oh, that's Alice.
Yeah, it remains closed even when you try to unmute.
Okay, let me find him.
Yeah, no, it says the host has stopped.
Okay, I found him. Let me. Is it Temi Sovelad?
Yes, that's right.
Yes, you can go ahead.
Okay, you can go ahead.
Okay. Thanks. Good evening, Dr. Zondo, and good evening, colleagues, and thanks, Dr. Zondo, for this wonderful talk and quite an excellent presentation. Can you hear me?
Yes, I can hear, Prof. Thank you.
Thank you so much. We really appreciate taking time and preparing this talk, because I wish all the orthopedic registrars, orthopedic consultants are joining, because the way you have looked at it, it covered at all levels in terms of the clinicians on the ground. And I think it's very practical. It shows the importance of taking history, the importance of clinical examination, and also the approach that when you do investigate, one should not go and just order all the tests.
Yes,
be guided by your examination and by your findings.
Yes,
and the same applies in terms of the management. Thank you for that. And we have more than 430 attendees, to me, which highlights the interest in the topic in terms of the spine and back pain, because some of us, especially at our age group, we're really struggling with this. And
yes,
we want to find out the advice as to how to deal with it. And I think you have covered it so well and in such a detail. Thank you very much. And I think you've mentioned something that we as clinicians often cross boundaries, and we advise people on the areas that don't belong to us, or on the areas that we have a limited knowledge on, of people who say don't go for surgery. That will happen. And I think that is important that we bring that up and we talk to it, and we say we must know our limits and the importance of referring to those with expertise in the field. Instead of keeping them for too long. With us. We really appreciate your time and what you've done for Clinix, and I'm hoping many colleagues from all over the country joined and looking at the numbers. But I think you've got people joining from different disciplines, not only from the clinical side, and I see their physios and other disciplines have joined. And also thanks to everyone who have attended, and thanks for your questions and thanks for your compliments. We really appreciate this. I think at the end of the day, is about the making sure that the people of the country who come and look for services in the different facilities, including the facilities that are owned by clinics, including the facilities that are owned by governments or public or private, patients or people get the best in terms of treatment, which is informed by people like you, Dr. Zondo, in terms of having the expertise that you pass on to others, to students, registrars, and to this kind of grouping where we get updates. We thank you very much, and thanks for everyone for attending, and thanks Dr. Kinoshi
thank you very much for sharing. Thank you very much. Thank you very much, Prof. And I think it remains for me to thank the board of Clinix Health Group and EXCO for continuing to sponsor these webinars, and we will continue continue arranging the webinars for as long as you, the audience, continue to log in. And please, you may volunteer yourselves as speakers in future, or you can suggest possible speakers for us who we can approach for any topics also that you may choose as well. I think it remains for me to thank my partner in dealing with this webinar tonight. In the background, Ms. Aviwe Makakuka, who has been assisting with the technical assistance at the back and support at the back. Thank you very much, Aviwe. Good night to everyone.